let me introduce Dr. Anna Barac to you. Dr. Barac is a cardiologist here at Inova Heart and Vascular. She is the chair of the cardio-oncology section for the Inova Health System, and she also serves as the medical director of the cardio-oncology program. This leadership position represents a substantial enhancement in Inova's cardio-oncology program made possible through the generous support of Dan and Gail D'Angelo. The program provides comprehensive cardiovascular care for patients across the cancer treatment continuum from diagnosis through survivorship. Prior to joining Inova, Dr. Barac was the director of MedStar Health and Vascular Institute's cardio-oncology program. She is a professor of medicine at Georgetown University, was the founding chair of the American College of Cardiology Cardio-Oncology Council, and served as co-director of the ACC's annual live course on advancing cardiovascular care in oncology patients. She serves on the editorial board of the Journal of the American College of Cardiology, is a senior advisor for the journal and the journal's sort of subsection on cardio-oncology, and is an editorial consultant for the Journal of the American College of Cardiology Heart Failure. Dr. Barac is a superstar with an international reputation, and we're just thrilled to have her here. Dr. Barac, I'm going to turn the program over to you now, and I will be back at the end to pass along some questions. Thank you.
Wonderful, Warren. As you know, this topic is near and dear to my heart. And I've been really privileged to work with the multiple. I think you should be able to see my slide right now, correct?
Yes, full screen now. That's perfect. Thank you.
Excellent. So I've been really privileged to work with many health professionals, but most importantly, I know this is watched by the patients. I want to say I stay inspired by patient stories. And that's how my journey started more than 20 years ago. So today I'll give literally 5 slides, and then I hope we have good discussion on what you need to know about heart health, cardiovascular, not only the heart, the vessels that connect the body before, during, and after breast cancer treatment. So this slide is a reminder of how far medicine has come. And this is speaking to our field. About probably 20 years ago, it was still a paradigm. If you have cancer, you see oncologist. If you have heart problem, you see a cardiologist. And those two entities would never need to talk to each other because, in big part, because both diseases did not have good prognosis. So many of the diagnoses were not ending in good outcomes. So probably around 20 years ago, we started saying, well, patients are living longer. We have, and today, I think for many breast cancer, we have normal, what we say, life expectancy. That means if you complete the treatment, the length of life should not be shortened because of the diagnosis. And we realized that there's a lot of opportunities to learn and improve heart health treatment. So the point of this slide is really, this comes from the European Society of Cardiology guidelines, where we said, when we think of the heart risk, and here that's shown in this vertical axis here, so the heart risk can go from low to high. But when in a patient who is diagnosed with breast cancer, there's a big difference whether we are talking about a patient before treatment, during treatment, and after treatment, because things we need to pay attention to are different. Before treatment, we talk about risk stratification. Does that patient have diabetes? Does that patient have history of heart problems? Do they have history of heart failure, atrial fibrillation? What do we need to do? And do we need to talk to an oncologist to decide what kind of treatment they're going to get? So that's an active conversation. Many of this happens behind the door. If you're a patient, you might have never seen this, but this lives in the protocols between cardiologist, in our case, cardio-onc person, and a cardiologist specializing in this area, and oncologist. Once the treatment starts, then we are, in addition to optimizing the cardiovascular risk factors, we start looking, some treatments are associated with heart effects, and then we follow. So during that, And during that time, the risk inherently goes up. So that risk of heart problem during cancer treatment can go up. And it's our job to recognize it timely, make sure that the treatment doesn't need to stop. And then after cancer treatment, and that definition is fluid. Some patients ask me, so what if I'm now going to be on cancer treatment for 10 years? Well, or lifelong. Just like the definition of survivorship is changing. So in that space, we are slightly different. We are no longer monitoring those therapies, even if they're given for a long time, they often do not require close monitoring, but then we focus really on building further cardiac health. So in the next couple of slides, I'll show you some of the high level really progress that has happened in my field over the last years. So again, an emphasis for the first time cardiologist, and your cardiologist would ask, okay, where are we in cancer treatment? Are we before, during, or after? So what do we know before? First, we've learned that we have shared risk factors between heart disease and breast cancer. And here they're put into groups. So some are not shared, but some, such as age, age makes both heart disease and breast cancer more likely to come. Diet, family history of individual diseases makes it higher. Alcohol intake, hormone replacement therapy, obesity and being obese or overweight, and lack of physical activity, as well as tobacco use, they all have been recognized. They play a role in development of both and progression of both cardiovascular disease and breast cancer. So then you could say, is there good news? Well, there is. And I want to show for now, we are more and more trying to prove. So it's not enough that somebody, and I always tell my patients, please don't use Dr. Google. If you want to read a good paper, I'll give you a good paper. And this is an example of a wonderful paper that was done using Women's Health Initiative. That was a large study that included almost 100,000 women in the United States. It was designed in the late 90s. And then many of these women were followed for years afterwards. Among those women, we've analyzed women who developed breast cancer, and we looked into something that's called Life Essential 8. So Life Essential 8, we'll talk about that in a second. That's all those healthy habits. So healthy diet, healthy weight, healthy physical activity, good blood pressure, no smoking, good lipids. And we looked how presence of these Life Essential 8 in women diagnosed with breast cancer affected new onset of heart disease. Good news for women who were adhering to healthy habits, meaning had higher scores on the Life Essential 8, they had less heart problems. Why was this important? Because one is to hypothesize maybe this is true, but you have to prove it. And this was a nice example of the positive effect of Life Essential 8 on the risk of heart problem in women with breast cancer. So what are they? If you come to our clinics, we have this available. This is from American Heart Association, education on how to improve what I think should become part of our culture. I think this needs to go to elementary schools. Everybody needs to know what Life Essential 8s are. That's eat better, be more active, quit tobacco, get healthy sleep, manage weight, control cholesterol, manage blood sugar, and manage blood pressure. So these are the common concepts. And now you will tell me, but when I was diagnosed with breast cancer, they gave me all this education and I was going to get 3 different treatments, including this chemotherapy, maybe targeted therapy, maybe radiation therapy, and all of them can increase risk and can lead to heart complications. How do I know? Do I stay safe? Well, this is a complicated slide, and I was just, as Dr. Warren Levy mentioned, I'm involved with the education of providers or of your physicians, and we just had a 2-day conference to discuss this very topic. One simple thing, most of these side effects are rare. However, the good news is monitoring for these side effects is embedded in the cardiovascular treatment protocol. So for many of them, we look for And if you have new onset of symptoms, something that's unusual, you will share with your team, typical with the oncologist. And this is when we come in. For some, we actively monitor. Some of you might be getting echocardiograms or electrocardiograms when you are at the visit. Again, not something that you have to wake up in the morning and say, hey, do I have this side effect? If you are not feeling different, you're able to exercise, you're probably, and not having symptoms, you're probably not having it. And how do we do this? So you could say, well, nobody mentioned. Well, because it's built into our oncology protocols. It's built, sometimes you might be sent for a test, and the reason for it is for us to understand if there is something on the echocardiogram, for example. This slide is from another very recent paper where we put together with our European colleagues, and this is a phenomenon that is true across the world. Our advancements in breast cancer treatment have improved, and today the patient who is diagnosed, whether here or somewhere in Europe or else in the world, is probably going to get similar treatment protocol when it comes to gloves, and should have this similar approach to cardiovascular health. So on this slide, we have in blue what is oncologist role. And if you have a breast cancer, of course, you will be seeing breast cancer oncologist, and they'll discuss the type, the stage, the prognosis. That will mostly determine treatment. Today, most treatments are eligible, and our role from heart side is to say, hey, what are the cardiovascular complications? Do we have pre-existing risk? Do we need to modify the treatment? And if not, what do we need to watch for during the treatment? So in blue, again, oncologist role, and then you see how we overlap with our oncology colleagues in the baseline risk stratification. That means if you saw your breast oncologist and you tell them, either I have a history of problem with the heart, and I've seen a cardiologist, they might tell you, why don't you see somebody from our cardio field so that we know, do we need to monitor you differently than somebody else? So we are really trying to move. You've heard a lot about personalized breast cancer treatment. That's dependent on the individual tumor characteristics. Sometimes we don't have that granular evidence to follow everybody differently, but we certainly use your individual risk factors in creating the baseline cardiotoxicity risk stratification. And based on that, you see that we collaborate, and this is half orange and half blue, on the treatment surveillance. That means, how do we follow you? Do we do an echo? Do we do it every 3 months? Do we do it every 6 months? Some treatments don't require echo. And this is a really sort of a blueprint of how cardio-oncology programs work, and that's what we do at Inova as well. And then finally, this is going to be my last slide. And again, comes from the recent literature on how does, and this is leisure time, physical activity, how can it preserve cardiovascular health in women treated with breast cancer? This was a trial that was supported by the National Institute of Health, where they included women with breast cancer, and then they randomized them to women reporting more activity versus less, and they followed over time. We know that after breast cancer treatment, there is a reduction in functional capacity, which means that we may be more tired, we may be able to walk less fast, or if we were running before, might not be able to. So overall capacity goes down. And what they showed in this trial, if the physical activity was maintained during treatment of breast cancer, even if that was leisurely activity, because often chemotherapy makes you tired, it was still beneficial on both exercise capacity as well as on cardiac function at the end of the trial. So I wanted to end on really a positive note. Sometimes small, simple solutions, in this case, I would say they help the heart, but they also help successful completion of breast cancer. And with that, I will want to close with our contact information, and I will have Dr. Levy and Rona give me all of the questions.
All right. Well, that was a lot of information, but we're going to kind of go back over some of this stuff slowly, and we're starting to get some questions in the Q&A, and I've got a whole bunch here too. So thank you very much, Dr. Barac. It's a scary topic, and I'm sure women who are diagnosed with breast cancer are, have so much on their mind and are very concerned. But let's talk about some of the basics. So, which of the breast cancer therapies sort of concern you most about developing cardiovascular complications as part of their treatment protocol?
So this is an excellent question. So while there are two therapies that always require monitoring, and they are that what's one is a chemotherapy infusional drug called anthracyclines. It also has a name: adriamycin, doxorubicin, red devil, you name it. It's still an important part of many bad cancers regimen. And when you say, I wouldn't like to say that it concerns me the most because it has gotten very safe, meaning that we have now done many, many trials trying to make it safer. So as a cardiologist, we have put people on, let's do prevent this. But in most trials, there has been no evidence of heart failure. So it has been present in less than 2%. So that means if 100 people, well, less than two will have significant heart problem. So it really doesn't concern me. What concerns me the most is that there could be patients if all this knowledge that we discussed today is not out there, or if the oncologists are not aware. For example, patient who has history of heart failure, patient who has a problem in the past, patient who has all these risk factors that we were talking about, and somebody tells them, forget about those risk factors. We just need to focus on your cancer. Don't exercise. Don't worry about diet. Don't worry about blood pressure. That used to be the case. So like just focus on cancer. Well, then heart disease certainly almost no, particularly if some of these drugs are used, but even in the setting of more softer chemotherapy, they can lead to problems. So that worries me more, that the cancer treatment type itself, again, because of all the monitoring and all the work we've done, the therapies have gotten really safe.
Yeah. So, chemotherapy, you're really worried more about developing things like heart failure or inflammatory
Yes.
problems. Someone asked, if I got chemotherapy 20 years ago and now I found that I've developed coronary disease, is
Yeah.
that related, or are you worried more with radiation and possible coronary disease? And then someone said, if I'm getting radiation, is there something I can
No.
do that reduces the risk to my heart? Should I hold my breath, not breathe, take a deep breath? Are there mechanical things that we can do to try to reduce risk? Sorry, that was
Yes to all.
a
So
mouthful.
I'll try to break it. I'll try to break it down. The first question about 20 years ago, chemotherapy. So chemotherapy per se typically doesn't lead to coronary disease. So, and I would say, I think the statistically, it would be more likely that coronary disease came from other reasons. So high cholesterol, genetics, the radiation therapies that were used before year 2000 were associated with higher risk if the breast cancer was on the left side. So somebody who had breast cancer in the 90s and received radiation therapy for that reason would be at a higher risk. For example, we know that even if the breast cancer was on the left versus right, because at that time we didn't have all these protective strategies. Contemporary or today's modern radiation therapies most often use one of the techniques that you mentioned, and they tend to use all the combination of them. How do they do it? Well, today they have CT. So if anybody is receiving radiation, they do a CT. So they see a contour of the heart, they see where the vessels, key heart vessels are, and then they plan around it. They can also put the patient in prone position, so face down, to make it that so that the heart is not in the radiation field. They could do deep breathing techniques. There is a new thing such as called as proton therapy. There has been no evidence that proton therapy is better than photon for the heart, and that's mostly because photon therapy has gotten really safe. So I would say that today's risks are much lower and already in place.
Yeah, and so much has changed over the years. And both of us have seen just incredible progress as an interventional cardiologist, when patients used to get mantle radiation and then
Yes.
it would develop a bad coronary disease that was hard to deal with. You talked about life's essential eights, and one of the things that I was thinking when you presented that was, well, if you had everyone conform to life's essential eight and really do all those things, that would reduce their risk of cardiovascular disease as well. So are breast cancer survivors or breast cancer patients any different than the general population, those who conform to minimizing their cardiovascular risks by following all of those guidelines? Are they reducing their risk more than the general population, or that's just they're reducing their risk because that's what it does?
I I'm always biased. I feel I honestly feel that my patients, so often breast cancer patients, try harder. I feel that there's
Ah,
that
that's a good
survivorship.
point.
We have looked into some cohorts, and we've seen reduction in cardiovascular disease in general, and of course that's very hard to quantify. But some of the most stellar examples come from my patients who are survivors and who say, you know what, I've survived breast cancer. I'm not getting this another problem. If there's something I can do about it, I'm doing it.
More
So I've
motivated.
learned
Yeah.
exactly, very motivated,
Yeah.
very motivated.
So here's the question, and I know you kind of talked around it, but I've got to think that if I was a patient, I'd be asking this question: should every patient with breast cancer see a cardio-oncologist? Or how do you really say these are the patients who definitely should be seen by a cardio-oncologist, and these patients, only if something comes up along the way? How do you,
Yes.
how do you divide that group?
Yes. No, I talk to our oncologist all the time. We have these discussions, and it's very fluid. Not, absolutely not everyone. It's not necessary. It's not needed. We will not. And I think if we spread the culture, it's going to be even less needed. So, like oncologists, however, the patients who should see a cardiovascular specialist who works in cardio-oncology field are patients who have, again, history of heart problems, and that can be all sorts of things. But any history, if you've seen cardiologists and they were suspicious of something, uh, I think it's a good idea. I would mention it to oncologists, and they will certainly know and say, hey, this is who I often see a patient on one or two times if they are followed by somebody else, because the definition, the decisions about the treatment are a little bit specific. So they require like close conversations with oncologists. For example, there are patients who previously might have had a history of a different type of cancers, might have received already anthracycline, and now need a new anthracycline for the new breast cancer. That would be a typical example to see me, because I would call oncologists. We would do an echocardiogram. We'll see if we need something else. I would talk to patient, how much are you exercising? I always told them it's not only echo, it's what echo shows, how much is your functional capacity, how much can you exercise, what are the biomarkers showing, how is the blood pressure control, where are we? And that would be a decision making with an oncologist, saying how much would we lose from oncology side by losing that anthracycline? Do we have to take it? And we do share decision making. So I would say everybody with a history, prior exposure or prior receipt of potentially toxic therapies, uncontrolled blood pressure. Blood pressure is a big one. I call it a silent killer, and that's what it is. Because if blood pressure would hurt like the tooth hurts when you have a toothache, nobody would have problems
Right.
with it. So you don't feel it, you don't know. So if you know that you have high blood pressures, that needs to be put under control. And that can be done by internists. Sometimes we like to know if they were not successful, we would rather use, for example, cardioprotective agents as opposed to some others. I can see some questions very specific coming
Yeah,
in.
yeah,
The,
right. So let me ask you this. I want to give you a chance to brag for a second. Um, I think we have an incredible cardio-oncology program. And we were thrilled to steal you away from MedStar and bring you over to Inova to really put our program on steroids. But why don't you tell folks a little bit about our program, how it works? It's, multi-centered, and just take a couple of minutes just to talk about how the program works through Inova.
Well, it came out of the need. So I will say that so our program is we have 9 providers. Some, and as you know, it started really in collaboration. It was one of the first examples of excellent collaboration between Virginia Heart and Inova. And I remember when it started because we had the cardio-oncology course. So American College of Cardiology put forward a course. And yes, I was part of the people who said, you know what, we need to educate the entire cardiovascular, physician force about these things. So people who are passionate and who want to do this, they need to have access to education. And 2 of the leaders, Dr. Epps and Dr. Shea, came for the course, and then they told me, hey, we are starting at Nova. What do we need to do? So the course was like 2 days. Okay, this is what you do. And we were all learning. So every system, what I did at MedStar, they did at Innova. So how is it different now? Well, fast forward 8 years later, we cover the entire Northern Virginia territory. And the main concept of having a program is that a patient who is being treated we were just had our meeting half an hour ago, that if somebody is treated in Gainesville, if somebody is treated in Woodbridge, if somebody is treated in Ashburn, they do not need to call and make an appointment with me or the different and travel 20 miles to get to that appointment, because we are adding to already busy schedule surrounding breast cancer treatment. And the idea of us 9 being part of the team is that we share those risk stratification protocols. So all oncologists are using the same concepts they are referring, and when they refer, then they refer to the program and they tell us, hey, this is where we are seeing. So whether you are seeing, doctor in Loudoun, in Ashburn, anywhere in Northern Virginia, it should be the same practice.
Yeah,
So, and
so
I'm
it's
very proud of that.
no, it's great, and it's very convenient for patients because they can get care in their own regions, in their own neighborhoods, and it's just a wonderful program. There's a bunch of questions here about aromatase inhibitors, and if you've been on them for a long time, are we especially at increased risk, and what should we be looking for? What
Yes,
symptoms should we be bringing to someone's attention?
absolutely. So aromatase inhibitors are a special type of hormonal or endocrine therapy that is typically used for a long time. So, and that is part of the official survivorship. So that belongs on that first slide. That's not, that's to prevent cancer recurrence, or in the metastatic setting to treat the cancer. Aromatase inhibitors do not have direct effect on the heart muscle, so there's no risk of heart failure. However, they can affect cholesterol and blood pressure. So during that time, there's no need for additional echocardiograms. We monitor mostly by monitoring cholesterol and by monitoring blood pressure. So if the blood pressure is well controlled, cholesterol is on the roll, and I almost never stop aromatase inhibitors because cholesterol is high, because we have gotten so good in treating that cholesterol. We have multiple tools. If statins are not working, we use something else. So that has been a success story. And I also see one question. I can take that one really quickly. There's a person who is on Kadcyla. That's a TDM1. Typically, the Kadcyla is a form of HER2 targeted therapy. The risks are not cumulative, and they are reversible. So when Kadcyla is stopped, even if there was some heart issue, I don't know if there was, the risks does not persist after getting off medication. So there's no long-term effect of Kadcyla. Also, you would probably get echocardiogram if your last echo was normal. We do like to see you during the first year of survivorship, making sure, or you will get an echocardiogram, but there's no longer term risk.
That kind of brings me to a question, and I wonder about this. How often do you get into a situation that you're following a patient during therapy and you're starting to become concerned about some cardiovascular manifestations due to the therapy that needs to alter the therapy? And how does this affect the patient's ability to get the best possible care without exposing themselves to too much cardiovascular risk. Is that a rare bird or is that more common?
That's a rare bird, but not that rare in my clinic. That is one of the I think all of our cardiologists since we started are getting better and better. So that results that the patients sort of who comes to see me are almost the ones who have heart issues. So there's a new concept in that space called permissive toxicity. It sort of means we know that the cancer drug is going to cause potentially more trouble. But however, the risk of that might be 5%, 10%. Our heart function might go a little bit down, but it was very normal to begin with. On the other hand, oncologists could come and tell me, I really need this drug and I don't have an alternative. I don't have a good alternative. And then we modify the survey, meaning monitoring protocol. We say, you know what, we are going to take the chance. It's that shared decision making. We talk to the patient, we talk with the oncologist all the time and say, let's go with this. And this is how we're going to monitor. In most instances, we start, and if you see the problem, you can always pull back. Sometimes it is harder. There are drugs that might not be that quickly reversible, but I feel that with this approach, we are able to find that problem really early and then switch treatment, and not to switch treatment out of fear of problems.
I think that's kind of the key, what you just said right there at the end. Someone actually asked this question, and it's a good question. So that if you're seeing someone who is starting to develop some weakening of their heart muscle due to chemotherapy, does what's called guideline-directed medical therapy, do the medications that we use for not oncology patients, but regular cardiovascular patients who have weakened heart muscles, do those work as well for the oncology population as well?
They do. They were studied. And that's why, I mentioned in the beginning that those are the patients that we would like to see, because particularly if there is a little bit of high blood pressure, like sometimes in these patients, then we would rather, so as you said, GDMT stands for a beta blocker. That could be metoprolol, carvedilol, or a drug like losartan. So there are groups of drugs that were actually studied in patients receiving treatment for breast cancer, and they do work. So they work in conjunction with physical activity. So we start with typically in somebody that we would have signs of, even small signs of heart problem, something that we measure by fancy echocardiograms like global longitudinal strain. If you see that number, that's going down, we would just probably change one heart medication, put you on it, continue watching. Nothing different needs to happen to cancer therapy.
I bet a lot of our oncology patients have heard that term strain when they get
Yes,
echocardiograms. And you want
yes,
to take just a couple of seconds just to explain to them what it is we're looking at, because it's a very sensitive measure that helps us
yes.
understand what's going on with their heart.
Yes. So when we get echocardiograms, you'll see we use one measure which is very rude, and that's called ejection fraction, and that's the most Googled word after diagnosis of breast cancer. I saw once analytics. So ejection fraction just means how much the heart pumps, and if it gets 100 cc's in the heart and heart pushes forward 65, that ends up being ejection fraction of 65, and that's a measure of how much the heart pumps. So when that number starts going down, for example, now heart pumps from 65 to goes to 50, we start saying, that's not good. So since we realized we monitor for that change with echocardiograms, and people realized that we should look earlier. So meaning that, can we see on one echo before that ejection fraction drops? Because when ejection fraction drops, then the damage might have already happened a little bit. So we introduced something called global longitudinal strain. It's a fancy name for contractility. So when we look at that heart muscle, how much it squeezes, that's a shortening in this direction. And that's where that global longitudinal strain normal is typically minus 20%. So that's how much your myocardium shortens. That's important, because that we've seen that if that starts dropping, it's an early marker that ejection fraction or heart function may drop. It may not, but more likely it's an early, if the strain doesn't change, it's a very good predictor that nothing is going to happen to the heart. If the strain drops, no reason to panic. It's what we call a subclinical measure, means that nothing different needs to happen to oncology. However, we use that, and we've actually published a nice editorial with Dr. Harnden and Dr. Morrow in European Heart Journal. You saw a lot of references there on how to use strain to early, not to interrupt. We do not change therapy. We just look for that, and then we use that as a reason. Okay, maybe you can see a cardiologist. Let's get some beta blocker on board, and then keep watching. So I think that has been a success story.
No, I think it's great because what it's led to is early intervention, early attention, picking up on problems much sooner than we used to in the old days, which wasn't so long ago. I'm going to go through a couple of these questions real quickly. So if I had radiation therapy and I developed some heart damage, what can you do about it? I'm going to guess that they're talking about coronary artery disease, and maybe I'll even take that question as an interventional cardiologist.
I was just going to
We're
say,
going to treat you like anyone else with coronary disease. Now, that said, there is a caveat that some of the radiation effects to the coronary arteries are a little different than normal atherosclerosis, or what we call coronary artery disease. And sometimes we cannot be as successful with our catheter-based therapies in that situation, but there are still many ways to revascularize to improve the blood flow to patients' hearts. So that's just something you want to be sure gets picked up and identified, because we can certainly deal with it. With coronary artery disease, we always want to get to it before it gets to you. And we have lots of tools in our toolbox these days to manage that.
Yep. And I agree. And it wouldn't be different compared to somebody who didn't have radiation, who has coronary disease, or others. Sometimes it's also very hard to go back and to know what caused what. So,
Exactly. If I had right-sided radiation, do I have to be concerned about heart disease?
Typically not, particularly if it was in the last 20 years. If it was in the 90s, sometimes they need to radiate the lymph nodes here in the sort of mid area, so they might have affected one of the vessels. So I would say, however, the modern radiation, the last 20 years on the right side, no.
Okay. Supplements. People always want to know about supplements. Are there any that are helpful or good? Apparently in Europe, they are pushing certain supplements to reduce cardiovascular risk around therapies. What are your feelings about supplements?
So I have to say this, it really depends. So, and I've learned to call statins vitamins. I feel that they're like proven vitamins for the heart, because they really work for people who need them. So I will really say it depends on how high the risk is. If LDL cholesterol is really high, if lipoprotein A, I'm now going into preventive cardiology, and that's our next thing. Like, there's a lot of when we were starting with cardio-oncology, I was like, well, that's all heart failure. No, today it's all prevention. So, and this is a great question. It really depends on what the risks are. Most supplements have not been studied or proven to work in a rigorous way. Meaning, if you ask me is how effective, then the question is effective on what? On preventive stroke. There is no good trial to show that any over-the-counter supplements prevents stroke on a long run by reducing cholesterol. So statins are masters there. They lower the risk of stroke and heart attack in people who have elevated cholesterol by 20, 30, 40%, depending on how high that risk is. So that's why they are FDA approved. That's why they are regulated. And yes, there are some people who cannot tolerate statins. In that case, we see what the risk is, and then we use other drugs. We're really fortunate. We have injectable drugs. We have a way of because we are really not, when we say effective, I don't like to define effectiveness like lowering cholesterol. Like cholesterol doesn't hurt. What hurts is stroke if it comes. So we want to be focused. And my question is always effective. If we're asking in effectiveness of reducing stroke and heart disease, then it's supplements just don't have strong evidence. I see that it's mentioned tamoxifen. Tamoxifen, it's an interesting, so it's used typically for younger women, so it's premenopausal women. And tamoxifen does have favorable effect on cholesterol. So you'll all see that it looks good because it's a partial estrogen modulator. So a cholesterol panel doesn't work. I don't typically have to put patients who are on tamoxifen on they're often to be younger women again, and on tamoxifen, so they don't need statin in general. The problem with tamoxifen is usually the blood clots. So, drug is just a different drug. So I would say individual, but I wouldn't, the question is a little bit, I can sense that there is more layers to that question. So that would be best. If there's more after all my explanation,
Well,
we'll see you.
I think, I think the important take home, and I think all of us in cardiology hear this all the time, that um, if you have vascular disease, all right, if you have vascular disease, not if you're just, uh, primary prevention, but if you have vascular disease, the only way to reduce your risk in lowering your cholesterol is with statins or one of the other pharmacologic drugs. Going on a diet and reducing your LDL by 10 or 20% really has never been shown to reduce your risk.
That's exactly
So
right.
there's a difference. And people have to remember that when we treat people who need to be treated, that we're doing it to reduce risk, not to make the numbers look better. It's to
That's
reduce risk.
exactly right.
And
That's exactly
it's
right.
an important concept. So you got a great question. Someone who obviously knew you in a former life, and I'll keep some of the personals out of it. But how do we encourage our oncologists to confer with and work with cardio-oncologists like, well, I'll say this, like you and Claudia collaborated when you were at MedStar.
Oh my goodness, that's a question to know. I really think that the times are changing, and Warren, you can comment on that. There also used to be the time when many cardiologists were saying, "No, you don't need anything. Like just like we're not going to do anything. Like you're going to die of cancer or you're going to die like it's really new generation. I think many I've published many papers with oncology colleagues, and I think the way is to spread the word, keep the education. We work, even the professional societies are coming along and recognizing that this is an important thing. So I think it's out there, and I tend to not to focus on naysayers. I think there's so many positives, and I have to say that even sometimes people who maybe do not believe in and it would often see the need when the real problem comes. So
Well,
I cannot think of a person who would say, "Oh no, I don't want you to see."
right. I'm going to
Coming.
give you a shout out because I think you've done a great job, not just in organizing a cardio-oncology program, but in educating the oncologists in this region regarding the importance of this type of surveillance and program and cooperative, multi-specialty care, that patients will do better in the long run with that collaborative approach. And I've been very impressed with the oncologists that they know to reach out, and they know to
They do.
to get their patients seen. So I think this has been a rapidly developing field. I mean, it hasn't been that many years, and it's grown tremendously. A couple of questions about, how long am I at risk? Especially, let's say, after chemotherapy. You talked about the recovery phase. How long should I still see a cardiologist, or how long do I have to be concerned that some of these therapies could have an effect on my heart? I'm now a couple of years out from therapies. Is it something I need to keep, under surveillance for?
So this is an interesting thing. To be very honest, I don't think we really know in the breast cancer world, because some of the therapies are really new. And I see some, well, if I don't have risk factors and I'm exercising and doing well, I would say probably if there was no doxorubicin and there's no drugs like trastuzumab, or there were no drugs that you needed the echocardiograms for, and no risk factors, and you're exercising, no symptoms, you probably don't need somebody who will focus on. There is the biggest data we have on the long-term toxicities, where the long-term is needed, is for children, adolescent, and young adults. So if you had, that's typically not for breast cancer because it happens really, as early as in the 30s, but not in childhood and adolescent. And the therapies that are given for those tumors are heavier. So they have to have lifelong surveillance because the doses are higher and they're given to developing heart. In general, if again, I feel that those slides with physical activity, control of the risk factors, if there was no, only anthracyclines really have a longer term, but the doses today given for breast cancer tend to be low and the drugs tend to be safe.
Yeah, much different. So that kind of relates to another question up there, and I think you just gave the answer, and that's, hey, I'm getting radiation, I'm getting chemo, but I have no cardiovascular risk factors. I'm otherwise healthy. What can I do to protect my heart? And I
Yep.
think that comes back to the essential eight again, doesn't it?
It does. It really does. And we don't really we should make it a success. I wouldn't worry extra. It is really it's safe. We are living in a good time when we can make a good impact. Oh, I
Um,
see a question about physical limitations and
yes.
somebody cannot
Yeah,
exercise.
sure.
So that's an important one. And Warren, I'll ask you to back me up on this one. Heart doesn't really care whether you are doing Zumba or you are moving and you're laying flat on the floor and you're working out with the little dumbbells, or if you're whatever raises your heart rate, it's going to work. Stationary. So some resources. There is Life with Cancer. It's a resource available at Inova Shar Cancer Institute. They really have phenomenal exercise physiologists and a group that specializes in fitness during cancer treatment, after cancer treatment. They're open to all patients, and I've referred a number of patients with them. Then I think what's helpful is that they can modify the type of activity depending on the limitations. Also, if somebody is limited and you're, for example, receiving physical therapy, I hear that very often. Oh, my back is killing me, I'm going to have to PT. Well, ask PT what's safe. Whatever aerobic activity is safe, and you can do it on any type of equipment. It will work. Heart doesn't really care whether you are on a $10,000 bike or you're just dancing in front of a YouTube video. It really it's going to have
Or
beneficial
right.
effect.
Or sitting in a wheelchair, raising your arms up above your head, or doing
Exactly.
whatever it is
Yep.
just to be active. Absolutely.
Yes.
There was an interesting question. This kind of goes to the pre-therapy, pre-diagnosis. Let's say you have someone who knows they have a BRCA gene.
Mhm.
And so they're under careful surveillance, but are there other things that they should be doing from a cardio-oncology perspective other than being followed closely?
Well, I don't know if you know this part of my history, Warren, but we actually asked that. We did a study. There were some data coming from basic science and the animal studies that in animals with a BRCA mutation, there was an increased risk of heart problems. And we looked into that in patients who had BRCA mutations and received, they are typically treated with doxorubicin, which can cause trouble. And in absence of high blood pressure, we did not see additional damage. So I tell patients that was now looked at afterwards, and we looked into survivors. So no additional heart risk. They do need to be on lifelong monitoring for different types of cancer. But good news is we did not see a higher risk for heart failure. So yeah, the
Interesting.
same
Yeah.
token thing, very important to pay attention to blood pressure and cholesterol in that group. Small data here and there, but no additional risk for heart failure.
And just heart healthy lifestyle, diet, exercise, all of that stuff. Um, so a question was raised, like I need to be treated. They told me the chemotherapeutic agent it puts me at more risk of potential heart damage. What should I do? And there are no right or wrong answers. And I think you touched upon it, but you may want to touch upon it again, that everything is risk
Yes,
benefit, and we
exactly.
don't have to be so afraid because we can manage many of the heart issues now, right?
That's exactly. So I see that there are people are maybe somebody's going to pull my slides and say you didn't write that drug. There's no reason I don't want to be writing like 15 different ways the drug can be called. If the drug can cause a problem, you will have an echocardiogram before. Just ask your oncologist, hey, is my heart looking okay? Is this kind of drug that I need to have the heart checked? It will be part of the protocol. Trust me, I have not seen, and now I've been at Inova for 2 years. We work with the oncologists across the region, with Virginia cancer specialists. We really work with all oncologists and other individual oncologists in the area. It is embedded. So just ask the question, do I need an ultrasound of the heart that is part of the treatment? And then if the ultrasound is normal, there's no, like, things can happen to us. I always tell the patient, yes, but you can also get on a beltway and get hit by a car. So it's, the risks of some drugs have really gotten small. We shouldn't avoid therapy because of the heart risks.
Yeah. Do you have a different threshold for intervening for lipid levels in someone who is post-therapy for breast
Yes,
cancer?
I do. Yes, I
Yeah.
do. Yes, I do, because some of the aromatase inhibitors I saw, do they usually continue to rise? It's hard to tell. They're not really good studies, but yes, I keep looking at them. And sometimes it's a tricky question, because aromatase inhibitors are also, they're given only in post-menopause. Some women are pushed into menopause, so we call that, induced menopause. So you're having somebody who is not even 50 and is now in menopause and will be kept in menopause because of the need for aromatase inhibitor. So I do check the cholesterol levels in them, and typically once they're checked, they can be checked every 6 months or one year. We do not need to do more frequent than that monitoring.
Right. So, but you do have a lower threshold. So if
Yes, I do.
you're having a different discussion with patients than I am. Um,
Yes.
so someone, one of the questions was, if I all I need is a lumpectomy, I just need some minor, just a surgical procedure for breast cancer, is that putting me at increased risk of cardiovascular problems,
No,
other
no.
than the fact that we share risk factors?
That's it. That's exactly. So that goes back to your original question. We just because, this is the risk factors of cardiovascular disease don't go away, and we can also be very granular. The data that I showed you for shared risk factors, it doesn't apply universally to all types of breast cancer, because you can say, I'm sure there's people in the audience, do you have a young person of 30-year-olds with zero risk factors and gets bad breast cancer? So that's a type of breast cancer that doesn't fall under that category. And then we look at those patients and their therapies in a different way. When we say personalized, that really means personalized. So
And that was the
doesn't cover
question.
all.
Yeah, that was the question I was going to ask you. The age at which a woman gets breast cancer obviously has important prognostic, ramifications. The 30-year-old with breast cancer is very different than the 80-year-old with breast cancer. But does that change how
Absolutely.
you're approaching these patients from a risk factor
it
perspective?
it definitely changes. So first, in many younger women, there is often less of the cardiovascular risk burden. However, because they may have worse breast cancer, and also the risk, as you know, many of the breast cancer, they are diagnosed early. They are the big part of the treatment is to prevent recurrence. So there, the conversation with the oncologist is very different. There we would take much higher risk. So meaning that, because the cardiac risk in a 30-year-old person is different, and we know that they have reserve, then we say, well, you know what? if you do have to ask a question, what is the bigger problem right now? So, and a 30-year-old with a breast cancer, that's breast cancer. So we look, if, for example, you ask me, what if the heart is not normal? And you have a 30-year-old, well, we're going to sit and say, but still the biggest problem is breast cancer. What's the best therapy we need to use? And then we just ask the question, how do we best protect on the heart side? Yes, we would monitor more often. So for that young person, I would be monitoring more often. For many young women, I don't need to see them. Their oncologists, they know they don't need to send me. They don't need to refer a 30-year-old woman who is exercising, who's doing fine. And yes, it's receiving that therapy, but the doses are being monitored, the echo is being monitored, and there is no higher risk.
Well, Dr. Barac, this was amazing and really educational. I learned a lot.